So I think in the interest of time, we will start. So it is really wonderful to welcome Professor Angela Webster to the Statewide Biobank today, who will be talking about on use of trial data and integrating evidence for clinical care. So a brief background to Angela. She's had a very impressive career. She is currently a leadership fellow with the National Health and Medical Research Council of Australia, and she is a clinical epidemiologist. She's also a nephrologist and a transplant physician, and she trained in England, Scotland, and Australia. So she studied clinical epidemiology at the University of Sydney, and she was awarded her PhD in 2006. And she now has a number of different positions. So she is a professor in clinical epidemiology within the Sydney School of Public Health, within the Faculty of Medicine and Health. And she's also Director of Evidence Integration at the NHMRC Clinical Trial Centre here in Sydney. And finally, she is a Senior Staff Specialist as well in renal medicine and transplantation in Westmead Hospital. And I think that she's also affiliated with a research centre based at Westmead as well, the Westmead Applied Research Centre, where she's a principal investigator. So Angela, it's really a great pleasure to welcome you to the Statewide Biobank, and we're very interested in hearing about I think you're going to talk to us a bit about the HASANA initiative and essentially how we can reduce research waste by maximising the use of health data and data linkage. Thank you so much for joining us today.
Well, thank you very much for having me. It's an honour to be here. I'm not wholly proficient with Teams, so we'll see how we go at speaking to the void and talking to you today. So I just wanted to acknowledge that I'm on Gadigal land for the people of the Eora Nation, and it always was and always will be Aboriginal land. And things I'm going to talk to you about today, I wanted to talk to you probably a slightly different perspective than the one you're used to when you think about biobanks. Is I want to talk about reducing research waste from the trial perspective, from trial data that's generated, and maximising the value of that research, because we all know that trials are hard to do. And we want to make sure that that the useful information that they can contribute doesn't end when the trial ends. I'll do this in terms of contextualising the trial activity in Australia, and also thinking about the research life cycle, and blowing my own trumpet a little bit. Something I spend a lot of time doing with my team at the Trial Centre is doing what I call meta research, and that's research on research. So it's kind of the epidemiology, the landscape, the research environment that's going on, because I think that can add a lot of perspectives and help you perceive a kind of bigger strategy and a bigger direction of travel than when you look at when you're in your own little slightly blinkered world, which I often am when I'm doing analyses or working on big projects. I want to talk about some initiatives that are facilitating the on-use of data in Australia at the moment, particularly the infrastructure project run by the Australian Research Data Commons called HASANDA. And I also want to talk about just a very little bit, just a pointer on where things are moving towards at the end, which is about kind of equity, diversity and inclusion in research and in clinical care, and making sure that we generate evidence that's applicable to everyone and not just the average person. So the first part of my talk is about increasing trial value kind of within and beyond the funding cycle. And as with many things, there's a lot of pictures in my talk about balance and stones, because there's always extremes and often the middle grounds where we want to try and inhabit, but we want to balance it out so that everything is equally shared. So this is a project we've been working on in my team at the Trial Centre, the evidence integration team, for well, at least the last 2 years, and that is to develop an updated report on the clinical trial landscape in Australia. We did this once before, my predecessor did this once before up till 2015, and this now covers the period of time. It's updated until the end of 2020. So it's just about to be released. It's a little bit embargoed, but I can tell you some of the key findings which I think are okay to share. It's based on the data we have in the Australian and New Zealand Clinical Trials Registry, the ANZ-CTR, which is part of my remit to manage in my role at the Trial Centre. The ANZ-CTR also receives a feed from clinicaltrials.gov, which is the big American trial registry, of every trial that mentions Australia as a site. And so between using ANZ-CTR data and including this feed from the clinicaltrials.gov, we have estimated and validated that we have representation of at least 95% of clinical trials, randomised trials and other registered clinical trials that are going on in Australia at the moment. And we can see when we look at the kind of overall landscape of trials that over time, trials are becoming smaller. Trials are becoming less collaborative with overseas partners, and this isn't just an effect of the pandemic. This was happening before that and has been sustained since. We're seeing that trials are shifting back from large-scale implementation type trials, rolling out treatments, to earlier stage, kind of much more research and development stage. And we know that the proportion of trials that is commercially funded or has some kind of commercial representation within it has been roughly the same. The proportion hasn't really changed over time. It's about 45% of trials in Australia. And that over time, fewer trials have become, fewer of the trials that are registered are randomised, which is slightly disappointing given we know that that's the highest and least biased level of evidence for new interventions. We don't know a lot about how much the COVID pandemic has interfered with the trajectory of change, but I can give you some hints, and I'll move on and talk to you about that. So a case study is exactly using what's happened during the pandemic, because we know that a lot of things in life have been kind of condensed, crystallized, and you know, there have been some benefits, but there's also been some trade-offs with operating in the pandemic. And this is a piece of work that we published last year with my team, which looked at the landscape of COVID trials and trial activity based on interventions for COVID in Australia. We saw that we did this was measuring the early pandemic response. So we did this analysis up till November 2020, so before the big wave of cases in Australia. And we looked at intervention trials only, so trials that had at least one recruitment site in Australia and were about the prevention, diagnosis or treatment of COVID-19 and its direct or indirect health effects, so it included things like long COVID. And we were interested really in understanding the Australian contribution to the global health agenda. So we're not just inward looking, we're interested about where our place is in the world. And also because if anything has shown, the pandemic has shown us that we need a lot more coordination and collaboration internationally to keep the world safe. And we wanted to understand what value we were adding and what the lessons were. So these were our key findings in that piece of work. We saw that the research scale-up was impressive, and in fact, of all the trials there, they were planning to recruit over 34,000 participants in Australia, but 24 were not yet recruiting and 4 had been withdrawn after they were registered. Over 70% had no commercial sponsor, so more of them were independently led, but only 12% of the trials focused on people at highest risk of poor outcomes. So here's the equity and diversity thing coming in early on, is that we weren't targeting the trials at the people who were most at need. We did see that there was some cost in terms of rigor and prioritisation. There were no protocols available, so transparency and kind of scientific rigor was perhaps wanting. There was a lot of fast track procedures, some of which was great to get trials moving really quickly, but there was some real gaps in the early research being done in Australia. There was no research on public health messaging, nothing on community transmission, nothing on vaccination hesitancy. So all the things we really needed to know about weren't actually being prioritised. We did also see that there was an untapped potential in terms of innovative trial design. Like, trials have moved on from the parallel randomised design. There's new Bayesian innovations where we can do platform trials, umbrella trials. We can do basket trials where we're testing, and from the Biobank perspective, you'll probably know a bit about that, where we're testing treatments in a way to accelerate the answers that we get. There was a lack of remote and digital conduct that we saw. There was very few methodological innovations, although there were some innovations in the way that interventions were delivered. We found that many of the trials were underpowered for important outcomes. They had a very small sample size and there were low case numbers at the time in early 2020, and mortality was hard to measure. And there were early on in the pandemic some core outcome sets that were being recommended internationally that all trials and research focused on, and we found that these were underrepresented in Australian trials. What was most disappointing to me was that 80% of the trials that were registered had indicated that they weren't planning to share data. Now, this is in the context of a global pandemic where fast, accurate information was a priority, and these trialists were not sharing their data. So there were some strategic gaps that we saw that we needed to address in terms of the COVID-19 contribution of Australia. There was the upsides were fast-tracked funding, registration, ethics approval, publication and preprint, but none of it was joined up. There was no infrastructure for rapid collaboration, and so people were doing things in an ad hoc way, and there was a sense that there may be some bandwagoning. Everyone wanted a piece of the COVID pie and were doing things in a very uncoordinated way. It wasn't very joined up. There was no advanced methodologies applied, and you know, for me as a methodologist, this is disappointing because I kind of feel like you need a methodologist in every big trial, particularly when there's many millions of dollars being invested, and that's to try and make the maximize the design features that will give you efficiency and value for the research dollar. And the feasibility of data sharing was really untapped. Adding value beyond the trial, and adding value by, you know, more is always a bigger and more people collaborating is always greater than the sum of its parts, and we weren't seeing much of that as a signal in Australia in the Australian response. So when you put this in the context of some of the, you know, major funders of the research infrastructure and the research endeavour that happens in Australia, so the Medical Research Future Fund would be one big example, which is supposed to, these are the key drivers and the conceptual framework which the MRFF is constructed around, and we'll see that, you know, they wanted more Australians to access clinical trials, greater capacity of the research community and capability to translate their findings, to embed new technologies in clinical practice, and to engage and adopt new technologies and treatments. But we weren't seeing that this was being done in early on in the COVID pandemic, which was possibly the greatest pressure we'd ever seen on needing information fast and translated information fast. So that was disappointing. So how could we increase knowledge gain and value? Well, we could probably incentivize coalition, collaboration and platform trials being the kind of innovative design. We could facilitate trials, trial rollout and governance by having common infrastructure that we could share across people doing trials. We could incentivize thinking and doing beyond the traditional trial life cycle, where you design a trial, you get it funded, you go to ethics, you carry out the trial, you analyse the trial, it's finished. That shouldn't be the end. That data should be unused and shared so that we can gain more knowledge from it, particularly when we realise that some of those underserved populations were not being included or focused on. When you join many trials together, you can increase the proportion of people who are those underserved populations and realise more value and target and effects of treatments and interventions where it's most needed. And we could balance the bigger picture of research in terms of not just concentrating on basic science and clinical research, but also on public health prevention and health service delivery, which was very underserved in some of those early COVID trials. So kind of using that case study and that example to think more broadly, what about data sharing willingness and attitudes? I just wanted to highlight the work of one of my PhD students, Aidan Tan, and my postdoc, Annalena Seidler, who published this article back in 2020 on data sharing, and particularly trialist plans at registration, their attitudes about the barriers and facilitators of data sharing, and to just look at what we can learn from that and think about to facilitate data on use. So what do? We use the ANZ CTR, which is a great resource for better research, and we looked at information of data sharing intentions up until December 2018. And it was all the intervention trials that had been registered during that time, and then we tried to do a survey of all of the trialists that we identified, but we got a proportion of that, about a quarter responded about to get a better understanding of exactly what was driving some of their declarations. And that survey looked at their in principle support of data sharing, their intention to share their own data. So of course it's one thing to say you like something, but it's another thing to do it. To try and get to the bottom of their concerns about data sharing and what was stopping people sharing data, but also to try and look at what was facilitating data sharing and what was a barrier. And just to give you an example of what we can find in the ANZ CTR as part of the trial registration, and of course all trials must be registered before they can be commenced in Australia and elsewhere. And this is the kind of thing we see. So at the top you'll see a data sharing statement where they're intending to share data and what they wanted to do, how to access it. And at the bottom panel, you'll see the kind of data sharing statement we see when trialists have said no, they don't want to share their data, or they're not intending to share their data, and the reasons that they quote. And what we saw overall from all of those studies was that there was a really low intention to share data. IPD here stands for individual patient data. So that's the line by line records from the trial of who participated, their outcomes, their demographics, their characteristics. And we saw that just slightly under a quarter were intending to share their data and 3/4 were not. We found that the data sharing intent was lower for non-randomized trials, was lower for trials with industry involvement, and was lower for earlier phase trials. So phase 1's the more kind of data discovery phase. I was interested in seeing the reasons for not sharing data, and they came in down to 3 main themes, which are highlighted here in red in the table. Concerns about privacy and consent, that somehow it would be breaching personal privacy of the participants if they shared the data for on use. They had concerns that the data that they provided would be misinterpreted, misused, or there'd be some secondary analysis on from their trials that they felt would mislead could be misleading. And they also had some concerns about their own self-interest. They obviously thought that they may think of new uses for their data of their trials, and they wanted to have the data available to them as they thought of it, and for it to be their gain from analysing it. They also wanted to prioritise publishing their own findings before they allowed other people to gain from the sweat and the tears that had generated the data. Contrary to, the converse of that is what were the reasons for sharing data for those that were sharing, and again it was slightly different. There were for some there was an administrative requirement. It was a necessity for them to share data as a condition of their funding or the research environment they operated in. Some were very keen on promoting open science and transparency and good scientific, conduct, and allowing other people to replicate their work. And some felt that by sharing their data, they gain more academic recognition, and the dissemination of their work would be greater and quicker if they shared their own data for on use. So kind of the flip sides of the coin there. So if you think about the health research life cycle from funding to ethics to trial registration to publication and post-publication sourcing of data into data repositories or archives, then we can think about pathways to bridge the gap to try and maximise the value we get from all these data and the on use and the sharing of it. And of course, I've represented this here as a horizontal line, but really it's a circle, because really this bottom arrow going back to the funders again is that, we should be able to keep using data and keep generating new things and keep asking for funding to generate more data as a more efficient way of generating new knowledge than starting again and constantly doing more and more trials. It can help map out a very strategic research agenda. So I just wanted to share some other work. This is Aidan Tan, another PhD student of mine. Some work is currently underway. We've just presented this at a congress in the States about looking at the data sharing policies that exist across that research life cycle, and working out what is the commitment and the utility of some of those policies. If they're there, are they making a difference, or how could they be improved such that we see an increase in data sharing and not these perceived barriers? And so Aidan looked at funders, the 55 largest public and philanthropic funders globally, and the 55 largest private funders. So for us in Australia, it would be NHMRC and the MRFF in the first line, and the private funders are things like the Bill Gates Foundation in the States or something like that. He also looked at all national ethics committees that we could identify, 124 of those. We looked at all of the trial registries, the 18 trial registries that are part of the International Trial Registry Platform run by the WHO. We looked at the 5 highest impact peer-reviewed scientific journals across 59 fields of medicine, which came to 273 journals. And we looked at all of the data research repositories that we could identify in medicine, in the health field, which was 410. Funders, what do we find for the public funders? Public funders should leverage influence of their funding. It's taxpayers' money, after all, that they're investing. We found that 55% of the health research funders recommended data sharing, and that was 15% who required it and 41 who 15 recommended and 41% required data sharing. They were more likely to recommend it if they were pharma or biotech funders, if they're in a high income country, and if they're in North America. And so the public funders were a bit on the back foot with this. In terms of ethics committees, this was a real untapped potential. Of the 124 national ethics committees that we surveyed, only 3% recommended data sharing at all. One specifically recommended, had a data sharing statement, and only one specifically recommended sharing COVID-19 data. We had a little look at what was happening with COVID because we thought, there's an imperative there. And all of those were in high income countries. So ethics committees have a role here, but they're not stepping up to address this crucial part of the research trial landscape. The most common investigator concerns we know were privacy, informed consent and ethics approval. So even if the ethics committees published their own recommendations at circumventing these things as part of the ethics process, then that would be immensely helpful. Trial registries, these have a great role in data sharing. They're probably currently not meeting it either. Of the 18 trial registries in the WHO's platform, only one recommended data sharing and none specifically recommended it for COVID-19 trials, but 15 required a data sharing statement at the time of registration, but that statement could be, no, we're not going to share. So there's a bit of an untapped role here too. Of course, trial registries only capture intervention studies, usually randomized trials, and there's a lot of other medical research that goes on that isn't part of that, that doesn't use that design. So maybe there could be a role for clinical trial registries in recommending or actually supporting data sharing more critically, but also across other kinds of research design. Now, journals are interesting. Of the 273 peer-reviewed journals we found, 64 recommended or required data sharing, but for some of them it was only the data sharing statement. Impact factor was not associated with whether or not they recommended data sharing, so it wasn't just the kind of the leading journals, if you believe impact factor is a proxy for that. It was it was not a factor. So our interpretation of this was, although it was a high proportion who recommended it, there's a lot of noise but not a lot of action. You could require a statement, but it might say, no, we're not going to share the data. They didn't really do much to promote it, so it's slightly lip service. They could definitely do more and move away from that, and ensuring data sharing requirements are met does the end result, and the academic currency that many investigators use is journal publication, so they probably have more of a role to meet here than they are admitting. Oops. So data repositories do have a role in facilitating data sharing because they are literally housing the data itself. We found that only 12% recommended or required data sharing. But their facilitation of it might help address other sharing barriers. So the misrepresentation of data or misleading second data analysis and academic credit could be given for sharing or depositing your data somewhere. And of course, the FAIR principles here, data in repositories needs to be findable, interoperable, accessible and reusable. So this is a very clear framework to use for use in that. And I'll talk a bit more about that in terms of the context of Hasanda. So that's looked at the research lifecycle. What about the views of the people who use the data, the views of the people who are meta researchers? And this is another PhD student of mine, Kylie Hunter here, who's been looking as part of her PhD on perspectives and responsibilities of the receipt and secondary use of data in health research from the people that have requested and are getting these data. So she, she thought again across the life cycle of design, conduct, analysis, reporting and access and reuse of data. And this is what she found. She found that, in the design phase, there was the responsibility of seeking ethical approval or waivers of consent for on-use of data. This is in the design of the reuse project. And that probably co-drafting of sharing and access agreements with the data provider or the data custodian whose data you were reusing, offering to involve the data provider or the data custodians, the original PIs or CIs of the trials, an opportunity to give input into the protocol and analysis plan or to be involved, what we have run into is when we're using data from multinational trials, is that different jurisdictions have different legislative and regulatory requirements about how data can be shared and reused, and that adds a layer of complexity. So, you know, thinking ahead and designing that into the initial trial is really critical. Preparing and sharing data management plans and allowing the data provider to publish their own work first before you go ahead and publish the unused data output is kind of critical. In terms of conduct of the on-use project, requesting the de-identified data in the dictionary in the least effort format, so doing the hard yards for the PIs if they can't process or prepare data, offering to do it for them. So clarifying data elements and data dictionaries and understanding is really critical. In analysis, there's the on-users of the data need to demonstrate that they've got the required clinical knowledge as well as the technical knowledge to carry out the project they're using on, and only to analyse the data in the way that has been agreed with the data providers. In terms of reporting, making sure that the data providers have an opportunity for input before anything is published, so that that meets the need of their concerns about misrepresentation of their data. And the access and reuse of the data that's been reused. So once again, spiraling up this kind of reuse thing is making sure that the data from the reuse project is also fair, findable, accessible, interoperable and reusable to everybody is crucial too. So that's kind of the whole life cycle of people who may use data. So again, all about balance. So this brings me to, you know, developing infrastructure to be able to share and unused data much more easily, because it's been, you know, my team here at the Trial Centre does a lot of individual patient data meta-analysis from a number of trials, sometimes, you know, 60 or 70 trials at a time. And it takes a lot of person time to administer and make sure that's all done, and to, you know, to overcome barriers and blockages to accessing data. And for a long time, we've said that there needs to be better infrastructure to support people to do that, because there's a lot of very common procedures, and it's stupid that we're all doing this, we're duplicating all of this effort when it could be centralised somewhat. And the Australian Research Data Commons, the ARDC, has developed the HASANDA program, which is trying to overcome that. And I'll just give you an overview about that. So what is HASANDA? It's the Health Studies Australian National Data Asset, and it's infrastructure. It's not data, it's the infrastructure. It's the skeleton from which you can share data. It's the roadmap for data sharing. It wants to facilitate sharing and reuse of trial data in a way that will bring extra value to the research community and Australia, and to increase the efficiency and value of the research dollar. So the focus is on research use of data, and its initial phase is to focus on investigator-initiated clinical trials. If they can work out the infrastructure for how trialists can share data, then the idea is that sharing of other data will follow. So the first phase was a consultation with trialists, and it's highlighted 3 important uses of secondary data. So you can use secondary data in research projects for secondary analysis, where you can use the data to generate ideas or to plan other studies. You can analyse data in a different way, or focus on specific subgroups to answer different research questions, or to understand prognosis, or certainly in the case of some of the work my team does, where we have extremely rare disease and we are using data from other trials to try and prognosticate for people who will never have a trial done in their population. The main part of activity of people like my team is to use trial data for meta-analysis and systematic review, and we're particularly interested not in summary level data from research publications, but from line by line individual participant data that we can reanalyze to understand more and more in depth. We also use network meta-analysis and prospective meta-analysis, where we are meta-analysing for specific outcomes or specific subpopulations of patients before the initial trials are even finished. So it's a way of condensing that research pipeline to be much quicker. The third use was replication, reproducibility and peer review, and this is where we can just good science, really, to make sure that science is replicable. Now, the timeline of the HASANDA program has been going on since 2020. The consultation phase in blue happened early on to try and make sure that what was going to be developed was meeting need, and it was across the and meeting the standards and the practices required by the research community. The red arrow indicates where we are right now. Infrastructure development is what I've been most closely involved in, although there is some culture and policy stakeholder engagement happening now. This will all be apparently finished and done, dusted and ready to be used by the middle of next year. So it's a tight time frame. The nationally distributed coherent infrastructure is literally the roadmap for how you share data and the skeleton from which you can do it, the pathways from which to do it. So who's involved? Well, there's the Hasander has appointed 9 nodes, and those nodes knit together to form a network across Australia. They're generally geographically distributed. They're not disease specific, although some of them are, but some of them are. I'll show you in a minute who they all are, but it's a variety of different stakeholders and generators and users of data who are in charge of their node, which is to bring together trialists in their area, whatever that might be, to facilitate and get buy-in to this process. So it's clinical trial networks, universities, medical research institutes that are independent, health service operators and infrastructure service providers are involved. So there's 72 partner institutions across the 9 nodes. And these are the Hasander nodes. The red one at the bottom here is Sydney Health Partners node, led by the NHMRC CTC at the University of Sydney. That's led by me. And although I have some very, very willing and hardworking helpers. And these are the other, so you'll see from the other nodes that some of them are disease specific, like the mental health node at Deakin focuses on a disease area of mental health. And there's also some cancer nodes on the middle of the left hand side, but others are research like our node, which covers a diverse array of content areas, research activity. This is our node and who it represents on the right, and all of the partners we have contributing to our node and on whom I'm acting on behalf of in this Hasander development process. So it's a wide variety of different partners. And the idea of Hasander is to try and meet the needs of all of the different stakeholders who might want access to using data or using trial data, again, beyond its initial trial purpose. And these might be trialists, data managers, researchers, or data custodians. And to do that and to try and roll out, there's been a lot of work done on understanding what the pain points are and what the sticking points are when you try to reuse and unused data, and the reasons by which you might want to do it. So just the middle column here, the researchers, people doing systematic review. This systematic review might be on genetic data, and it's really hard just by looking at a trial registry to find out who's got genetic data and who hasn't. And so that's a pain point. It's some granular information on what data is held, so which could be by accessing data dictionaries. Or the researcher might want to replicate or reproduce somebody's work, and they're not clear if they've got all they can access all the information they'll need. Or the bottom researcher might want to do a secondary analysis, and it's hard to, again, it's genetic data again at the bottom. There's also concerns of trialists themselves and of data custodians themselves here. So we're trying to work through all of these at the moment. So this is kind of our projects that we're working on to try and facilitate our node's contribution to building this infrastructure. So we've established our node. We've got the Hasander is establishing what it calls the federated services, which will be the first point of contact of anybody who wants to access data, and from there it will be channeled to the nodes. I'll show you. We're trying to work through the pain points of ethics and consent resources to try and facilitate and alleviate the concerns of that we've seen that trialists have, that by sharing their data they're somehow violating privacy principles. There'll be some work being done on the business model and sustainability of this, and if it can become usual practice then it's easy to keep going, but in the transition phase from design to actual real implementation there'll need to be a bit of work done around that. So the Sydney node has also developed its own communication and engagement plan to try and make sure that the people we represent and the people that are around us know that we exist and join up and and facilitate the use of the infrastructure that we build as we've built it, so that it becomes easier to gain greatest value from the trials that are being done. So we've got sort of sharing methods and objectives and how we're doing it at the top. And we're moving on to probably next year, 2023 onwards, we'll be starting to do some workshops with ethics committees, with study PIs and with researchers and clinicians and data custodians to try and work out what they will need to do or change to facilitate you to this all working. So how will it work in a practical sense? Well, understanding the information flow and the metadata discovery tools is probably key, and then it all starts to make a bit more sense. So the first thing is that the nodes will provide metadata for the trials that they represent to the federated services on the right hand side here, Hasanda, and they'll do this not by asking the PIs, but by taking the metadata directly from the ANZ CTR, because we know 95% of clinical trials in Australia and New Zealand actually are capturable through the ANZ CTR, which is the trial registry. That metadata will then be DOI minted by the University of Sydney in our node, and that will be fed up to the federated services, where it will be listed in a central catalogue that will be discoverable by any data, so that any researcher who wants to use data can go and look at a catalogue, a standard catalogue by the federated services, and have a look at what's available. Once that researcher down the bottom has looked at the central catalogue and decided that they want to access some data, they'll submit that request through the federated service, which will come either via the node or directly to the PIs of the trials to be considered. And only then, if the data custodians agree that they will share the data for that reason, then that user, that second researcher, will generate from the node a way of accessing that data. So IPD here meaning individual participant level data. So that's kind of how the schema will flow. Now, what will the Hasanda data catalogue look like in the federated services that sit at the top? Well, it'll be something like this. This is a mock-up of that's currently being looked. You'll be able to browse by theme, like COVID-19, mental health, cancer topic area, or methodology, platform trials, basket trials, and you'll be able to understand a bit more about the Hasanda process that we'll have to go through. When you find a trial, you'll see something like the right-hand side here, where you'll have a list of the trial metadata that's been lifted from the ANZ CTR. You'll understand what the data sets are and some of the tags that have been here, the keywords that are used, the type of study, the documentation that's available, which may be the protocol, maybe the data dictionary, and the time period it covers, and the location that the data is actually held, and whether it's ongoing, completed, the status of the trial, whether it's ongoing, completed, or yet to start. And so that's the kind of thing that we'll see. The trial metadata will be displayed something like this. This is an example on the right here, where when you click through, you'll see the study title, the organisation, the authors, the description of the study, and whether or not how you cite it, because the metadata itself has a DOI, remember, and who you need to contact to find out more, and the full description of everything that's involved. There'll also be a list of any related publications that were generated from the initial trial, because sometimes more information, or you can see what's been analysed or what's been done there. This is the kind of thing that you'll see. So the Sydney Health Partners CTC node data repository will probably be housed on a highly protected SharePoint area within the Sydney infrastructure, and probably requests will come in through a ServiceNow type portal, which we will facilitate. And if no data is going to be shared at all by anyone unless the data custodians agree for that specific purpose that the requests come in. And if the request's approved, then all the trial documentation will be funneled via the node to that requester, that researcher who wants to use it, which will include things like the statistical analysis plan, the data management plan, any publications, data dictionary, and the protocol. So it might seem that really it's all about kind of a balance and lining everything up and being on top of each other, but actually I think it's more about creating an environment where the cycle of research doesn't end and it just can keep going and going, and that the use and value is facilitated beyond what was initially intended. So I think I've managed to talk about most of these things. The very last point I was going to talk about was equity, diversity and inclusion in trials and clinical care. And that's a kind of moving point, and it's something that's been I've long been concerned with. And it's that we base a lot of our clinical practice on average effects of average trial participants, which certainly aren't the people who cause me most headache as a clinician. And that if we're going to base clinical practice on average effects for average participants, then we are perpetuating disadvantage, because those who are disadvantaged will never get to move towards the average because they may need more. Equity is about giving people what they need to have the same outcomes, and what some people will need more than the average patient to get the same outcomes. And so making sure that we have facilitated and shared knowledge of what those disadvantaged populations will need. They may be disadvantaged by disease group, by socioeconomic status, by language group, by gender, by sex, any of those things. If we don't make sure we've shared data in a way that will facilitate the knowledge transfer of what everybody needs, not just what the average patient needs, then we run into trouble. And this is a kind of increasingly fashionable, but increasing area of focus, I think, amongst many trialists and many trial disease areas, is to try and look at the EDI, the equity, diversity and inclusion of their trial and research culture, and to do something about that. If we, a great Australian example is, the underserved population of Aboriginal and Torres Strait Islanders, who often have a higher burden of disease and poorer outcomes than other groups in Australia, and yet they're hard to recruit to trials and not sustained. You don't need to do trials specifically in Aboriginal and Torres Strait Islanders, but I would argue that if you had data from a number of similar trials, you could then look at treatment effects and treatment harms across those trials in specific subpopulations like Aboriginal and Torres Strait Islanders, and understand more than you could from each trial alone. There are trade-offs and problems with the concept, thinking about in terms of the concept of research waste. There is a need on the left-hand side to leverage best value from trials and to respond to clear and present need, and the pandemic was one of those examples. It's very easy with a retrospectoscope to look backwards and say, oh, we should have done that, we should have done this. It's more about reflecting on using meta research, as I've shown you, to reflect upon what we could do better and making sure we've designed it in for the future. And replication is good science, and we do need to look back and be able to replicate what we've done to make sure we did it the right way, particularly as new methodologies or new statistical approaches are developed. We can apply those to data we already have to learn more. This is the point, everyone needs to benefit. This is the point that I mean about kind of EDI and the trial landscape and the trial environment. We have a diverse research community, so everyone should be able to benefit from data that's generated, especially the data that's funded by the tax dollar. But we also need equity in conduct and translation of the research evidence. The downsides of, research waste is that large international trials have a huge and substantial cost, and they need to be delivered before we realise anything else. Funding timeframes are often very tight, particularly with the MRFF, and they can hinder rigour and meaningful collaboration. And one of the ways to collaborate better is to ensure data on use. If you can't collaborate across trial groups at the time you're doing the trial, you can at least facilitate sharing the data beyond your own trial so that we can learn more from it. But this lack of infrastructure means that it's kind of critical that we get buy-in and use of the standard framework once we've developed it, because that could really, really overcome a lot of this. And there are some costs to making it sustainable, but certainly one of the costs is if we don't get buy-in from the research community and we don't get buy-in from everybody, then we won't have learned, we won't have gained. So everyone needs to benefit. And so rather than just it being a hierarchical kind of line from top to bottom, I do think the research lifecycle could be better reflected in balance like this, where it's actually we all need to be connected better, and we all need to kind of bridge gaps in evidence and gaps in what we do and be a bit more joined up. And I think this is a kind of nice way to end this talk, and I hope it's been interesting, and it's a bit different from what you probably are mainly concerned with as biobanks. And that's me. Just like to acknowledge all this is some but not all of my team at the Trials Centre here in the building that I'm standing in, particularly some of the people who are far more behind the scenes and less headline than me, but definitely deserve equal glory in what we've done here. And hopefully there'll be a little bit of time for discussion, but I can end now.
Thank you, Angela. That was wonderful. What a fascinating talk. I have a lot of questions, but I'm going to see whether certainly
stop sharing.
Oh,
stop sharing. Stop sharing. How do I do that?
I think I think there should be a message on your screen saying stop sharing.
Stop sharing. Okay, I found it.
There you go.
Better?
Yeah, no,
Excellent.
that was really great. If people have got questions, please maybe just pop up your hand, and then, oh, hang on, I can see. Yes, I can see we've got a question from Amanda Rush. Excellent presentation. I'm wondering down the track if you think it would be possible in Hasanda to link into trial IPD and even other data sets, e.g. MBS, PBS, to further increase value.
That's a perfect example, actually. The ARDC's first initiative was Hasanda and focused on trials, but there are other initiatives starting in the middle of next year which are focusing on clinical quality registries, and I hope eventually administrative health data, because a lot of what I do, although at the trial centre I'm mainly concerned with trial data, in my public health role I'd spend a lot of time linking up health data sets to create data platforms, data assets, and really I see it as a continuum. And in fact, when I was talking to the RDC about their next project, and they're saying, yes, we need to get involved with the people who are involved in clinical trial registries, I said, well, a lot of us are the same people. Like I'm a data custodian of a clinical trial quality registry for pancreas transplants across Australia and New Zealand. So I'm the same person. So it's the same concern. So you're very right. It's a bit siloed in the way that we're thinking about it, but it was a good place to start with trials. And the intention is that it eventually becomes a coherent kind of network of data sharing across all the different kinds of data that are involved. And for me, and my interest in biobanks is that, there's a lot of work linking trials to biobanks and creating biobank data sets from trials, but why isn't that also linked upstream to other administrative health data like admission to hospital data sets, prescribing data sets, death registries, all of the other, notifiable infectious disease registries, all of the kind of things that I spend my time linking to. It could all really be joined up. So that is the thought. It's hugely complex to get working, and the initial thought was that if you can make it work with trials first, then it will be easier to adopt in other areas. But I hope that's true. It's been a lot of effort and a lot of sweat so far, so I'm really hoping it happens. So I hope that's answered it.
I can see that. I think I just do have one question about right at the beginning, when you talked about your analysis of the, Australian New Zealand clinical trial register, and you saw things like trials getting smaller, less collaborative, fewer randomised. I mean, I was a bit alarmed by that. It feels like we're going backwards. Is there any reason why you think some of those things are happening?
There's a lot of different, we've banded around a lot of theories that we're now starting to try to test. So some of our meta research then develops hypotheses that we then want to test. I have to say that a lot of our meta research that we've done like this is completely unfunded, and it's really hard to get funding for, because it's not a trial, or it's not a new novel thing, or it doesn't appear to be novel, but without it we can't understand what's going on at all. So some of the reasons probably are pressures on the funding landscape, and there's definitely been, the MRFF is a great thing, but its rollout, it has some of the calls are quite narrow and in quite a narrow time frame, and so perhaps some of that needs to be rethought in terms of how we ensure diversity of trials that are being funded, and it's not just political fashion for the topic area. And so there's a little bit of that, which probably have to be a bit careful who's listening. But there's a little bit of that, but there's also strengthening the kind of R&D and basic science in Australia has happened. And of course, those kind of trials are often small phase 1 trials. And so it may just be a reflection that we've strengthened some basic science in Australia. It will be interesting to see, and one of the projects we're doing at the moment is examining the kind of later phase of the COVID trials in Australia and New Zealand, since we've had like greater case numbers here, but also looking at the downstream impacts of the pandemic on other research, because we do know that some research was halted. It was very, very hard to do. All my trials that I'm involved in were stopped during the pandemic. So but then early in the pandemic, we also saw, especially for multinational trials, that Australian recruiting centres, because we didn't have so much of the pandemic so early, took on far greater load of recruiting for those international trials than others did. And so there's some subtleties there that we need to understand better that isn't immediately available to us from looking at the trial registry records, that may need a bit more kind of thought out inquiry, which we are trying to do at the moment. So I've got some hypotheses, but I can't tell you the exact answers yet, but we're trying.
Yeah, no, that's true. And I think you're probably right that there's probably some things that co-segregate, such as early phase trials are going to be smaller and that kind of thing. Yeah. Does anyone else have any questions? Please just put up your hand or join in. I thought something else that you mentioned about, on reuse of data where the custodian needs to approve it. I mean, we're taking the same approach at the Statewide Biobank with the creation of, sample collections that can be open access. They can only be essentially made open access through the participation of the custodian. So it's interesting to see the same model in different places.
And I think that was very important. One of the difficulties we've had in kind of selling the idea of Asanda is the idea from trialists that if they say yes to participate and to have their metadata discoverable, that somehow that means they'll share their data with everyone who walks through the door. And that's not the case. It's going to be on a case-by-case basis. Sometimes it's been hard, especially with the very big trials with a lot of sites, particularly international trials, to try and work out exactly who are the key players, because the data custodian is often not the data manager, is often not the PI on the original grant that ran the trial, is not the senior author on the trial, on the main trial publication. And so trying to get trialists to focus on who they want to nominate into those roles has created another barrier and time sump, because they often haven't thought about this early enough to be able to organise themselves enough to have that kind of governance structure in place. And so some of what we're trying to do with Asanda is to encourage, and my team's kind of meta research work is to try and encourage people to think and design that in. And we're hoping we can develop some kind of toolkit to facilitate at every stage of the research journey, making sure that it's designed in.
Yeah, I mean, that would be great. And I'm wondering whether you do have any, like I realise that Asanda's sort of in the process of, getting organised, but do you have in the pipeline the idea of some case studies or early adopters that you will then follow and study?
Sure. Well, as part of the node bidding process, which was an open competition, we had to nominate trials that we would kind of experiment on to make this work, make sure this works. And so our node nominated the greatest number of trials across the Asanda infrastructure project. And we've got, I think, 12 trials that we've nominated, including some that are here at the CTC, some that are part of the other partners of our node, and also some that are finished and long done with, some that are in progress, and some that are yet to start. And we wanted some big international collaborative ones and some much smaller single centre ones. So we wanted to be able to test out the infrastructure on a whole array of different kinds of trials. And so some of the ones that we're using as kind of exemplars are ones that I'm directly involved with, so I can make sure we can access everything we need to make it work. But we've certainly it's a lot of goodwill, because of course it's effort that the trialists have to extend, and they've run out of funding. They thought their trial had finished, and now we're expecting them to do more work. So it does require some investment of time and energy for zero financial return anyway initially, but because of the buy-in to the good intentions of what we're trying to achieve here.
Thank you. We've got a couple of other questions. So Amanda's asked a question about challenges of biobank is essentially identifying biobanks that have got what samples, and some of it coming down to personal knowledge. How does accessing secondary clinical data at the moment work without Asanda? Is it a similar model? You go where you know the data to exist?
We tend to, yeah. I mean, for things like IPD, individual patient data meta-analysis that my team do here, we search for publications, we search trial registries to identify trials, and then we contact the PIs listed in the registration records. That's the way we tend to approach things. We also have knowledge from leaders in the field about what's going on and who's doing what, and we sometimes look through the very big funders. We look through their funding, their records of who they funded for what, because we can find out who's doing what there then. The idea with Asanda is that the metadata that will be discoverable through the federated services, the kind of top level, that will have sufficient information that you can see exactly who's got what, and probably down to the detail of data dictionaries, you'll see who's got exactly what. And that's the kind of parallel, I think, to the biobank type sample catalogues.
And Colin's asked the questions about patient consent, whether patients can decide whether their data can be made available to other studies. So I guess that's sort of dynamic consent, that kind of model.
Yeah, I mean, that's absolutely true, but the data that's shared is never identifiable. So the question we've run into similar considerations as well when we think about data sovereignty, particularly for Aboriginal and Torres Strait Islander health data, and how we ensure that we get buy-in from all. And of course, many at the kind of informed consent time of people opting in and out of clinical trials, often this is covered, particularly if you want to, I mean, all the trials I'll do, I'm always wanting to link data to something else, PBS, or just to make it efficient and worthwhile. And so there's Hasanda and the RDC have contracted out to CTIQ, a project at the moment to develop the exact kind of wording that would protect privacy and that patients could understand, that would ensure that there are no ethical concerns with the on-sharing of data. So that kind of process consideration is there. But you're right, most people who opt into a trial mainly don't care how it's used as long as their privacy is protected. I think they want to advance health knowledge, and so that's normally an easy step. It's very few people that I've consented into a trial who have not consented to that data sharing part.
Thank you. Angela, that was a fantastic talk. I've learnt a huge amount. It will be recorded and we'll certainly make it available to many other people. But thank you so much. Congratulations to yourself and your team. You're doing some fantastic work.
And thanks
for sharing that with us today.
Thanks everybody
who came along. Thank you.
Bye.
Great to see you. Thank you very much.